Hello, everyone, and welcome to the Natus Neurotraining Academy webinar presentation. I'm Dr. George Grodzik, Senior Global Medical Education Manager for Brain and Neuro Pathways, and it's a pleasure having you join us. Our webinar is entitled New Treatments for Refractory Epilepsy, featuring Dr. Lawrence Hirsch. Dr. Hirsch is Professor of Neurology, Chief of the Division of Epilepsy and EEG, and Director of the Comprehensive Epilepsy Center at Yale University. He has held leadership positions in the American Clinical Neurophysiology Society, American Epilepsy Society, American Academy of Neurology, and the Epilepsy Foundation, and is the lead author of the 2012 and 2021 ACNS guidelines on critical care EEG terminology. He is the founder and former chair of the Critical Care EEG Monitoring Research Consortium, which now includes more than 50 centers, and co-chair of the Medical Advisory Board of the Norse Institute. He has been an active researcher throughout his career, having published more than 200 peer-reviewed manuscripts and more than 100 reviews, editorials, or book chapters on topics including status epilepticus, all aspects of EEG, including intracranial recordings and brain monitoring in the critically ill, brain stimulation, epilepsy surgery, seizure clusters, rescue medications, sudden death in epilepsy, and anti-seizure medication use. He has won multiple teaching awards and is the co-author of the first ever atlas on EEG in critical care.
Thank you very much, George. Appreciate the introduction. So today I have a potpourri of topics we will touch on advances in epilepsy, concentrating mostly on treatment, but I will do a little bit of diagnostics as well. All right, here are my disclosures. Give you a second to look at them. Okay, so a lot of this is based on this special edition of Current Opinions of Neurology, where I was the guest editor on advances in epilepsy. So I will be basing some of it on there, but obviously I can't talk about all important advances in epilepsy, so this will just be a few selected ones. So I'll talk a little bit about diagnostics, including home recordings and some devices. I will not be talking about the ones in yellow, all very important things that are rapidly moving, genetics, high density EEG, electric source imaging, magnetoencephalography and magnetic source imaging, all very important diagnostics. I think there actually have been separate webinars or some or all of those. And I will not be talking about critical care EEG. I've done prior webinars on this platform for that. So I will talk about some of the other things. Then therapeutics is where I will concentrate on, including new medications, new surgical techniques, and neuromodulation. And then I'll touch a little bit about what's coming in the near future. All right, let's get started. So first we'll talk about diagnostics. So before you can treat somebody for epilepsy, you have to make a proper diagnosis. So what's new in there? Well, one of the new things is several years ago now, the definition of epilepsy changed a little bit in that it used to require 2 unprovoked seizures. Now it's adequate if you have 1 seizure and your chance of recurrence is above 60%. And that can happen, for example, when you have a lesion and a first seizure, and that would include something like post-stroke. If you're 6 months after a stroke, you have your first seizure, we already know that the risk is greater than 60% that you'll have recurrence, so that would qualify as epilepsy. Also, if you have a first seizure and you have definite epileptiform discharges on an EEG, that gives you a high enough risk to qualify as epilepsy. Thanks to the pandemic, which I don't say too often, but we did develop some very useful techniques. So one is the use of home video EEG increased dramatically. Certainly did at our place, where instead of having to come to the hospital or the lab to get hooked up and then coming back to get disconnected, instead a tech will go to the patient's house, hook them up, and we'll do video EEG without them leaving the home at all. So we're routinely doing that now. We do not do that for our pre-surgical localization, and we do not do that if we need to withdraw medications because it's not safe. But for people in whom you're just trying to figure out the nature of spells or the frequency of spells, that can be super useful. They don't need the inpatient setting. And similarly, telehealth for managing epilepsy has dramatically increased once we started getting reimbursement, which happened early in the pandemic. So hopefully that one will be a permanent change. Other ways of making a diagnosis, several people have said, including Dr. Tatum and Ben Badis, that everybody is walking around with half of an epilepsy monitoring unit in their pocket. And that is your smartphone or your video camera. So it can be super helpful to just get videos of spells. And I definitely encourage my patients and their families to try and do that, especially if we haven't already recorded one in an epilepsy monitoring unit. And there's one paper led by Bill Tatum that I was part of. We actually looked at the accuracy of smartphone videos, just regular outpatient videos of people's spells, whether they improve diagnostic accuracy on top of the history alone, which they absolutely do, and whether they give you the same results that an epilepsy monitoring unit stay does, which of course is the gold standard. And overall is about 89% accuracy by reviewing a smartphone video. And it was particularly accurate when they were convulsive spells. It was actually quite easy for the experts to tell an epileptic convulsive spell from the other types, most of which were psychogenic in this study. So you can see here for convulsive spells, the correct diagnosis was made by smartphone video almost all the time, with just some rare exceptions. And then coming soon are these ultra long-term recordings. Right now, home video EEG, we pretty much do 1 to 3 days of monitoring, but there's new methods of doing much longer recordings, many of them including sub-scalp ones, which are just implanted under the skin and can last months. Some other diagnostic advances are wearables for seizure detection. So there's a whole bunch of ways that people try monitoring patients to see if they can detect seizures in real time. This is partly for safety. As we know, unwitnessed convulsions are a significant risk factor for SUDEP, or sudden unexpected death in epilepsy. But also for diagnostic purposes and telling whether an epileptic seizure occurred or not, and for quantifying it. A lot of people are not aware of their seizures or not aware of most of their seizures. Most people miss at least some of their seizures. And if you talk about seizures that occur in sleep, more than 80% of them are not recognized by anyone. So it can be super helpful to get some objective data on how often these are happening. So there's a variety of devices. The most commonly used one for picking up convulsions, at least, are these watches, wristwatch devices that will pick up repetitive jerking. There's also things under the bed motion detectors. Some people just use traditional baby monitors with audio and video. There are video monitors that will just trigger a recording when motion is detected and can also send an alarm. There are other wearables that will use either EEG, heart rate, skin conductance, EMG or muscle activity, oxygen saturation, just with a regular finger O2 sat monitor, or combinations of those to try and detect seizure activity. Most of these newer ones will link with a smartphone. They'll have an app. They'll be able to send an alert to somebody, hopefully somebody who's in the same apartment or house. And none of them are perfect for detecting seizures, but they're pretty good at detecting convulsive activity, particularly the ones worn on one arm. If that arm is involved in clonic jerking, it will pick up the vast majority of those. None of them have been proven to prevent SUDEP, but we think that's very likely from the data showing that just having someone in the room seems to be protective. And then seizure dogs are another seizure detection method that that people have used. So this taken straight from the company website, so keep that in mind, but this is the one device that is actually FDA cleared for detecting seizures or for epilepsy monitoring. The rest of them pick up events or seizure-like activity, but they're not approved specifically for detecting seizures or cleared by the FDA for that. So this one's cleared for ages 6 and up. It's a wristwatch. It has lots of different settings. Before an alert is sent, it gives you a chance to cancel it. So if it's a false positive, for example, they almost always go off while brushing your teeth if you're using that alarm. So you can just cancel and say, I'm fine, don't send an alert. And you can also set the sensitivity. You can make it very sensitive or not so sensitive. It has all kinds of apps with it that will let you trend all kinds of things, your seizure diary, your sleep, your activity and movement. It can do things like your Fitbit does. And it can be exported in a form you can easily share with your doctor. I put something about the price here in US dollars, at least. Right now, according to their website, it's about $350. And then you have to pay a monthly fee depending on which features you want. There are actually several more rows not shown on this slide about the different options. But it's really based on how many people you want to share the alerts with, and then some of the features like sleep and activity monitoring. There are also apps that work with smartwatches, so a lot of people are using those nowadays. And so there's many apps that will pick up seizure-like activity. Most of them are based on actual movement of the limb. Sometimes it will also use either heart rate, either high or low, and also set off an alarm. There are ones that allow self-triggering. So if you have an aura, you can trigger something that says send an alert. And there are even ones that let you do that with a delay. So if the aura goes away, you can then cancel it. But if you don't cancel it, then it will send an alert after a set amount of time. And I have some of the names of these listed that are most popular or I've seen patients using. And then I've listed some websites here that compare these different devices or apps. These are all patient-facing websites, and a couple of them will even do financial assistance when that seems to be appropriate. Okay, so as far as even longer-term monitoring with EEG, so most of those, again, we're not EEG, they're based on movements and heart rate and those kinds of things. So there are companies developing these. These are not yet approved or readily available, but this is just an example of one where you have these little squares that just get stuck to the skin, and you can wear up to 4 of them in the forehead or behind the ear, depending on where that patient's seizures come from. And this one can be used up to 30 days. And with all of these, you get very long-term recordings, so you have to have the computer help you review them. So they have AI, artificial intelligence-based algorithms that will help at least label the suspicious periods of the EEG. And that's going to be more and more important as we get these ultra long-term recordings. It's just too long for anybody to look at the whole thing. You definitely need the computer to help. And then so that one's non-invasive. It just stick on. But there are many others that are subcutaneous or subscalp electrodes where you do need a minor surgical procedure and it gets implanted. None of these are approved in the US yet. I believe at least one of them is approved in the European Union. That's the first one here. But this is just some examples of at least 6 different companies developing subscalp devices. These get implanted, again, under the skin, a minor procedure. Many of them have something you also wear that talks to it by Bluetooth to stream the data and to charge. But there's all differences in these and how many contacts, how much area you can cover, how simple the procedures are, etc. So you'll be hearing more and more about this. And I think this will make a big difference for a lot of people, just to be able to have long-term implanted EEG recording. This is just a zoom in of those devices from this review article. So the other way to monitor long-term EEG is with intracranial monitoring. So the one system that is approved, it's actually been approved for 10 years now, is the responsive neurostimulator system, the RNS device. So that looks like this. So you get two leads. It can be a depth electrode or a subdural. It gets plugged into the device itself in the skull. And this will continuously read your EEG and stimulate as necessary to abort seizure activity. But now I'm talking mostly about the recordings, the diagnostic capabilities. So these are some of the things it can help with, because it's basically long-term intracranial EEG, and it stores samples whenever you can program it to store how you like, but it will store about 12 samples of the electrocorticography that last a few minutes each before the patient needs to download with a handheld wand onto their laptop, and then it can fill up again. So we've learned that this can help determine which side is predominant for people with bilateral seizures, mostly bitemporal. It's great for counting seizures, getting an objective report, for answering whether certain spells or symptoms are seizures or not. So that comes up all the time. I woke up not feeling quite right. Did I have a seizure before? Or I suddenly became very anxious. Was that a seizure? You can answer all those questions with this kind of device. You can identify future resection candidates in people who have multiple foci by recording for this long period and seeing if they actually have one predominant one. Having these long-term recordings has taught us a lot about different cycles patients have. So we've always known about the 24-hour or circadian cycles. We've known about catamenial cycles as well. That's monthly based on their menses. But it turns out most patients have these long, every few weeks cycles, and they can be quite strong cycles, and it's in men and women, and it's not clear what they're related to yet. There's also faster cycles with in less than a day, and several other patterns, and you can identify them in a given person. The data from these devices also has been able to show response to different interventions, like a new drug. So when you start a new drug, you can see dramatic changes in the recordings from the device. Basically, your epileptiform activity can drop pretty dramatically with a new drug that is going to be effective. And we've published that after 1 to 2 weeks, by looking at the data, you can tell whether a drug is going to work or not, which is way faster than clinically, where you usually have to wait up to months before you know for sure. And this system has been used to give seizure warnings as well. And a couple of our patients, we've programmed it so they actually can feel the stimulation. For people who are unaware of their seizures, you can give that. It's almost like giving them an aura or giving them a prodrome. So all of this kind of data is being used for what's called seizure forecasting. So this is from one paper using the intracranial device, the responsive neurostimulator system, and with fancy algorithms, including the intracranial EEG and looking at the cycles the patients have, both circadian and the longer term ones, you can predict what the chances of a seizure is going to be in the next 24 hours. So it's like a weather forecast. So here it says there's a 20% chance you're going to have a seizure today. And with that estimation, these curves are showing that that's actually was very accurate. It was somewhere around the 20% of the time they actually did have a seizure then. So it shows forecasting is possible. It's not going to say it's definite, you definitely will or definitely won't, but it can give you an accurate forecast, at least based on EEG. So this is being explored in more detail by this the large grants funded by the Epilepsy Foundation called the My Seizure Gauge Project. So it's using wearables, it's using some of these subscalp EEG systems, heart rates, diaries, moods, sleep, movement, all kinds of things, and being very individualized and seeing how well it can do this seizure forecasting. All right, so that was it for the diagnostics. Now we'll move on to the therapeutics. So starting with medications. So this is largely based on what was highlighted in this review article on new seizure medications from that same edition. So we're more often seeing that medications are approved for specific rare disorders or orphan conditions. So we have several drugs approved for Lennox-Gastaut syndrome now. We have a couple approved for tuberous sclerosis complex, including cannabidiol fairly recently. We have medication specific for Dravet syndrome, and for CDKL5, that's ganaxolone. I won't be talking about that, but that is a very rare genetic condition and a drug specifically approved for that and not yet approved for anything else. There are two new medications that seem to have efficacy that is significantly higher than anything previously available. And that's fenfluramine for Dravet syndrome. It's also approved for Lennox-Gastaut, but not quite as dramatically effective there. And cenobamate for focal epilepsy. I'll talk a little bit more about that. There's one that may be able to prevent epilepsy, and then there's some rescue medications I'll talk about. So first, a couple words on cenobamate. So this is in the same class of medication as some prior drugs like felbamate and meprobamate, and some of you remember ezogabine as well. So it inhibits the persistent sodium channel current. It's different than most of our sodium channel drugs in that manner, so it works differently. It's also a weak positive modulator of GABA A receptors. So in phase 3 clinical trials, this is kind of a summary of them, showing at the full dose, so not only was there a nice 64% responder rate, so that's how most of the trials report it, and that was much higher than the placebo rate. But the amazing thing was the people who were the super responders. 46% were 75% improved. 28% of patients had at least a 90% drop in seizures, and 21% were seizure-free for the 12-week period. And these are patients having very frequent seizures and having failed many prior drugs, often devices and surgery too. These are the kinds who get into our drug trials. So this was really unheard of to see 21% seizure freedom rate in clinical trials. It's virtually always single digits. So that really is different than prior drugs, and anecdotally and personal experience, I've seen that as well, where a significant minority of patients will have a dramatic response and become seizure-free. So then the next question is that just very brief and it's a honeymoon period? Well, I think the answer is no. So open label extension studies going out 4 years have shown that 10% of patients remain seizure-free and 24% had more than 90% reduction. Again, those super responders. Another study, 35% of patients who had failed epilepsy surgery with or without the vagus nerve stimulation had at least 1 year of seizure freedom while taking cenobamate. There are side effects. They're mostly the common ones of dizziness, sedation, balance, double vision, dose-related. There are significant interactions that you have to know about. So it induces 3A4, and it inhibits 2C19. So the inhibiting may be the most important part. Clobazam actually gets affected by both of those. So clobazam itself is metabolized by 3A4, so that gets induced. So you get more rapid metabolism into its active metabolite, the N-desmethylclobazam. But the desmethylclobazam is inhibited by 2C19. It's metabolized by it, and it's inhibited by the cenobamate. So you get very high levels of desmethylclobazam, and that is a significant interaction. And usually you will have to lower the clobazam some, particularly if they get any sedation at all. There's also a significant increase in phenytoin that usually has to be lowered as well. There's some pharmacodynamic interactions with other sodium channel blockers, such as lacosamide. You may have to lower those from a side effect standpoint. But as long as you're aware of these, as you add the drug, if they get side effects, you usually can lower the other drugs and continue the cenobamate. The other thing to be aware is if you do need to start it slowly because of the risk of a severe rash if you start it too quickly. That's very similar to lamotrigine in that regard. And since it's been done at the proper rate, there's either no cases or extremely rare cases of a severe rash. So once you're doing the proper rate, it seems to be a very, very low risk. So fenfluramine, so this is a 5-HT2B and C agonist and a sigma-1 receptor agonist. So it increases serotonin and GABA and decreases glutamatergic transmission. It's proved for both Dravet syndrome and Lennox-Gastaut. Perhaps its most amazing use is in Dravet syndrome. One, because it's specifically tested and approved for that, and two, because it was really dramatically effective for convulsions in what otherwise is a very hard to treat syndrome. So these are the numbers for decreases in convulsions. So you see 68% of patients had at least a 50% reduction in convulsions on the full dose, whereas the placebo rate was only 12%. And if you look at a 75% reduction, it was 50% of patients had that, compared to 2% of placebo. So that's really very impressive rates of control of convulsions. As far as side effects from this one, the main one is a decrease in appetite and weight loss, which can be a problem, particularly in children. If you recall, fenfluramine was part of the old fen-phen when it was combined at a much higher dose with another drug and was approved as a weight loss. It was actually taken off the market because of valvular cardiac valve abnormalities, so which is why when you give fenfluramine, even though it has not been seen in any epilepsy patients used at these doses, for now you need echocardiograms every 6 months to monitor these patients. So I mentioned a potentially preventative drug. So we really do not have any drug that's ever been proven to prevent epilepsy or affect the long-term natural history. So this is kind of the first case where there's a hint of that, using vigabatrin for tuberous sclerosis and starting it at a very young age. So vigabatrin is a GABA transaminase inhibitor. It decreases mTOR activity as well, which is related to the pathophysiology of tuberous sclerosis. Vigabatrin is very effective for infantile spasms in these patients. And so there was a pilot study started over a decade ago of infants treated with vigabatrin at the time that they first had EEG abnormalities, but before they ever had clinical seizures. This was called using preventive vigabatrin. And it turned out the patients who got that, rather than waiting till they started to have seizures, they were more likely to be seizure-free at 2 years of follow-up than the infants who just had standard of care. So it was 93% versus 35%. And they also found with long-term follow-up, many years, there was a lower incidence of drug-resistant epilepsy in the ones who got the preventative vigabatrin. There was less developmental delay, and there was significantly higher IQs measured 8 or 9 years later. So 50% of patients in the preventive group never developed epilepsy versus only 5% in standard treatment. So that was strongly suggesting it actually was an anti-epileptogenic effect, not just that it was hiding seizures, but that actually prevented the natural history, because when you waited till clinical seizures occurred and put them in vigabatrin, they ended up refractory much more often. So there's another study being done, a very high quality study called EpiStop, with some publications come out. I believe that's still ongoing, but they had follow-up at 2 years of age. And it was partially confirmed in that there was a decrease in clinical seizures, a decrease in infantile spasms, and a decrease in drug-resistant epilepsy at 2 years of age. But how much of that is a long-term effect on the natural history is not yet clear from that trial. So we stay tuned. There'll be more publications from that population. This is just showing the 2-year follow-up in that study, showing the group that got preventive vigabatrin and when they developed seizures compared to the ones who had standard treatment. So they virtually all had seizures by 2 years of age, whereas the preventive one, still about half had not had seizures yet. So very encouraging, and stay tuned for more details on that. So the next big medication advance in my mind was on rescue medications. So this has been a problem. The only thing approved, at least in the United States, for decades was rectal diazepam. And for adults, this was very rarely, if ever, used. You can imagine why. So a lot of people, including myself, were using off-label nasal midazolam. There are other countries who had at least buccal midazolam available, but this has been studied pretty extensively now, and we finally have some newer medications that are approved in the US. So prior to that approval, this is a review article looking at all the different formulations and methods of giving benzodiazepines acutely outside the hospital. So they concluded that buccal, nasal, and intramuscular were all better than rectal or intravenous use for out-of-hospital use. And it's better than IV because it takes a long time to get an IV in place. And obviously families aren't going to be using IV. So this is one of the first really nice randomized trials of nasal versus IV midazolam for status epilepticus. Turns out came from the veterinarians, and this was a study done in dogs. I just want an excuse to show some cute dogs as well. So they found that the time to stop status epilepticus in 44 dogs with epilepsy was a lot faster with intranasal midazolam than with IV because it takes so long to get an IV in place. So they concluded that nasal midazolam is probably a first-line option for dogs with status epilepticus. All right, what about humans? So yeah, it works very well in people as well. 2 formulations are approved by the US FDA. So the first one was nasal midazolam in 2019. That's approved for ages 12 and over. An important thing is the concentration. This is 10 times as concentrated as the intravenous solution that we used to use off-label. And nasal diazepam was approved in 2020 for ages 6 and over. Other ones are either coming out or already kind of approved. So there is an intramuscular auto-injector that's approved for use by the EMTs in the ambulance, but not for patient and family use. There's a diazepam buccal film. So this is something you just put inside your cheek. That actually has tentative approval by the FDA. So it means it's basically approved, but because of the nasal diazepam, they did not think it was substantially different, that they now have to wait for the exclusivity to expire from the nasal diazepam before that can be marketed. So it's basically approved, but they have to wait for the exclusivity license to expire for the other version. So this will be very good for self-administration for people to take in public. There's a picture of it here. Another one that is in late-stage clinical trials now is this staccato alprazolam. It's a device that it's basically inhalational. I have a tiny bit more on it coming up, but it works incredibly fast with a Tmax of 2 minutes and seems to get into the brain within 30 seconds or so. The pulmonary route is actually a super effective, faster route than any of the other ones. Then there's also, I mentioned buccal midazolam in Europe. It's not nearly as concentrated as the nasal midazolam that's approved in the US now. And you can just take the intravenous nasal midazolam and give it in an atomizer in a syringe. That actually works fairly well. But again, you have to give several sprays usually because it's not a very concentrated solution. So what do we know about the new nasal midazolam? So this was one of the pivotal trials in 300 patients who are having seizure clusters. And they define success as a seizure ending within 10 minutes and not recurring for at least 6 hours. And they found the midazolam was successful in 54% of cases versus 34% with placebo. And more patients treated with midazolam returned to baseline within 24 hours than those who got placebo. There were no breathing issues, and overall was well tolerated. There was then an open label extension with this of 175 patients and 2,000 seizure cluster episodes. This is mostly useful for the tolerability and safety. There is some nasal discomfort, but very rare for people to stop using it because of that, so it's not too severe. There were no reports of breathing issues felt to be related to the drug. There was no evidence that anyone was abusing it. Maybe that's because it's too expensive and hard to get. And it was found to be successful in just over half of patients with 1 dose and 80% with 2 doses, but there's no placebo control in these open label extensions. All right, then the next one that got approved was nasal diazepam. There actually was no pivotal trial for this because all they had to do was show that it was equivalent to rectal diazepam because that's already approved. So that they did show here, looking at the area under the curve for absorption. So this is rectal, oral, and intranasal. And the one thing that did come out was that there's probably less variability, both with the oral and the nasal, than there was with rectal. Rectal had quite high variability. And the company did have to use some fancy methods to solubilize, make it tolerable, and make it absorbed well. There were some prior formulations that were not adequately absorbed, and that's why they had failed. So this is now approved and available and has multiple doses, so it's easy to adjust. And again, it's approved for down to age 6. This was the medical letter, did a comparison of the two. The main difference is really just the timing. Midazolam is faster in and faster out. Diazepam will be a little slower in and will last longer. So it depends on your given patient and what the timing of their clusters and when they might have another seizure on which one you want to use. This is the diazepam buccal film I mentioned. It has been shown the pharmacokinetics are fairly similar to rectal diazepam, but with less variability again. So very similar to nasal, not yet available. Okay, so this is the inhaled one. So this is one of the first studies on this was given to patients who had photosensitivity on EEG. So they were able to repeat the photic within 2 minutes of inhaling this compound. And it's done just by taking one breath, which activates this device. During one breath, it activates it, it gets heated and aerosolized, and in that same breath, it's distributed in the lungs and then gets absorbed there. The surface area in the alveoli is extremely high, which is why it's able to be absorbed much faster than nasal, oral, buccal, or IM, or rectal. So they actually showed that by the first time point where they could measure it, the EEG response was reduced. So their abnormal photosensitivity was reduced within 2 minutes. So there's a trial going on now for people with seizures lasting more than 3 minutes or having clusters, fairly short clusters, meaning within 2 hours, you're likely to have recurrent seizures. So hopefully this will have successful outcomes in these trials and be available soon. And for choosing your rescue plan, it really just depends on timing, as I mentioned. These are some of the common uses where I use it. So people who have like clusters of myoclonus before they have their convulsion, that's a perfect case for a nasal benzo or inhalational when we have it. If they have a prodrome that lasts hours, then the diazepam perhaps is better. You could even give oral if you know their first one won't be for a couple hours. For prolonged seizures, that's off-label right now. That these things are not technically approved for status epilepticus, but we definitely still use them for that. It's better than giving nothing. So people with prolonged seizures, I'll often suggest they use nasal midazolam, and if all their seizures are prolonged, I'll even suggest they take it immediately when it starts. And you have to make sure that's that's not something they're going to be doing several times a week. But for people who often have prolonged seizures and their seizures are not that frequent, I'll just have them treat every one of them. I think that's good enough for examples on that. All right, now jumping now to surgical techniques and neuromodulation, which I will be going pretty quickly through these large topics. So just a reminder, drug-resistant epilepsy, which is when you should consider a surgical evaluation, just means you've failed adequate trials of 2 appropriate anti-seizure medications. So that does not take years, yet it's still an average of, most studies show an average of something like 20 years before people get their surgical evaluations. So please refer your patients quickly who have drug-resistant epilepsy. So these are just some of the advances in surgery, and this one's taken from this review article from that same edition of Current Opinions. So there's higher resolution imaging. We can pick up subtle dysplasia, whether it's with 7 Tesla or with artificial intelligence-based methods. We can pick up things like the central median nucleus of the thalamus with certain imaging algorithms and just particular ways of setting the MR machine. The stereotactic placement of depth electrodes has become extremely good and is extremely safe. There's ways of avoiding blood vessels. You no longer need angiograms, for example, like in the old days. So with these robot-assisted methods of placing the depth electrodes, it's super safe, and that's allowing a lot more patients to undergo stereo EEG and depth electrode placements. We've learned more and more about networks, so not everybody's epilepsy comes from a single focus that's curable. And it's a lot of people, it seems to be this network with multiple nodes, and you need to target specific nodes, including the thalamus and many of them. There's lots of standard atlases, so people are sharing and doing collaborative research. So this is just one example of one that was developed at Yale that we use. And epilepsy surgery still remains highly underutilized. So we have multiple class 1 trials showing high efficacy. Resection still remains the most effective procedure, especially for long-term seizure freedom. Again, guidelines are to refer after failing 2 medications. And many studies have shown the earlier you do surgery, the more likely not only you to get rid of their seizures, but also to have better functional and developmental outcomes. And that's particularly true in children. We are more and more studying the insula and operculum and recognizing epilepsies that come from there and mimic medial temporal lobe epilepsy. Dr. Damisa at our place has developed and published on this, putting the depth electrode in for recording and then using that depth electrode to guide the resection. It just helps keep your landmarks and makes it safer. We're also using stimulation to reproduce habitual seizures more often. That's been done for decades in Europe. It's becoming more common in the US. I'll show you one paper on that. And it has been shown that successful surgery will indeed lower the risk of death in epilepsy patients. So this is a very recent paper that just came out from Dr. Sivaraju here at Yale. So this was 41 patients getting intracranial EEG using 1 Hertz stimulation in virtually all of them in a very systematic manner of stimulating all the electrodes. So 56% of patients had seizures with the 1 Hertz. And the vast majority of those, 83%, were their habitual seizure, both clinically and on EEG. Most of the time, those were medial temporal or insular. So the rest of the neocortex was unlikely to get seizures elicited with the 1 Hertz. With 50 Hertz, you more often got seizures, but they were more often atypical, not the habitual. 16 patients in this study underwent resection. 11 of those were seizure-free. All 11 who were seizure-free had habitual seizures induced by the 1 Hertz stimulation. And all 5 who were not seizure-free did not have habitual seizures induced. So it's really looking like it's a good marker of the epileptogenic zone. And in our hands, 1 Hertz in this series never elicited a convulsive seizure, whereas the 50 Hertz did in 4 patients. So we are routinely using this as part of our localization. This is from that paper showing with the 1 Hertz stimulation, habitual seizures, atypical seizures, and the people who did not have seizures. Compared to 50 Hertz, a little higher rate of seizures, but more of them were non-habitual. And this is showing the red color shows where we stimulated in the whole group of patients. The green shows where spontaneous seizures occurred, and the little purple dots show where 1 Hertz triggered habitual seizures. And you see there's very good overlap. So this is neocortical, and this is also showing hippocampus, amygdala, and insula. The laser, or known as LIT, laser interstitial thermal therapy, is another big advance, having a much less invasive method of ablating a seizure focus rather than resecting it. It's very much better tolerated than a craniotomy. And it allows real-time temperature monitoring with an MRI, and this is just a picture of what that looks like. You can see it heating up in real time. It's quite remarkable technology. It's particularly effective for mesial temporal sclerosis, although still not quite as effective as traditional resection. So it's a little worse, but still pretty good. And for hypothalamic hematomas, I think it's the treatment of choice now. In medial temporal epilepsy, it's probably important to include the surrounding medial temporal areas listed here. There's a nice review on that in Epilepsy Currents. And overall, a review of studies concluded about 56% of patients will be seizure-free when they get lit for mesial temporal epilepsy, which is probably about 10 or 15% lower than with resection. It sometimes requires 2 trajectories to fully ablate the structures you want to, and that actually may enable the efficacy to reach the resection numbers, but we'll have to see on that one. Also, it seems that there are fewer language problems when you do the laser rather than resection in the dominant mesial temporal lobe. Oh, that's one of the advantages. Another method that's used in Europe that's similar but a little different is using the depth electrodes that are already in place for your surgery to do radiofrequency ablation. So these are very small ablations done, and they seem to give you short-term improvement or seizure freedom. And that short-term improvement is a great predictor that a resection of that region will work well for that patient. And some find it useful for periventricular nodule heterotopia as well. You can ablate multiple regions with your depth electrodes that are already in place. This is just showing an example of the 2 trajectory laser amygdalo-hippocampotomy. So the top is showing the left side is showing the amygdala and piriform cortex, and then the right half is showing really targeting the rest of the hippocampus. Okay, so neuromodulation, I'm going to try and summarize this basically in one slide. So these are the 3 devices that are approved. So there's the vagus nerve stimulation. These are in order of approval. So this is basically stimulates the vagus nerve in the neck. So here's the picture of it. So there's the devices in the chest wall, and the leads are in the neck. So nothing in the brain or in the skull. There is a responsive component that you can use the heart rate to trigger it. People can self-activate. The main side effect is voice change, sometimes a little coughing, but you can adjust the settings for that. It can exacerbate sleep apnea. And the average seizure reduction is 35 to 50% in systematic reviews, with rare seizure freedom. But it's been around a long time, has proven efficacy, improves quality of life. In fact, all of these improve quality of life. The responsive neurostimulator is actually approved 10 years ago now. That's approved for 18 and over, whereas VNS is down to age 4. There's studies in pediatrics going on now, and it is being used in pediatrics off-label. It can treat 1 or 2 foci. Again, this is the one that reads the brain waves and responsively stimulates when it sees abnormal epileptiform activity. You can treat 1 or 2 foci. And long-term studies have shown 75% seizure reduction at 9 years. And in real-world studies, it's even better at about 75% by 2 years. So that's probably a learning curve for that. For as far as seizure freedom, it's still the minority, but a significant minority will have prolonged periods of seizure freedom. And it gives you, I mentioned earlier, the recordings give you very useful data and sometimes identify surgical resection candidates. You get improved neuropsych outcomes, including specific to the region you're treating. For example, if you're treating medial temporal lobe epilepsy, memory tends to improve over time as you get their seizures improved. Deep brain stimulation was approved for stimulating the anterior nucleus of the thalamus for focal epilepsy. 5-year data showed 58% seizure reduction. Seizure freedom is a little bit lower than with the RNS, but still a significant minority will have prolonged periods of seizure freedom. So that's the picture here. Again, that's in the chest wall with one depth electrode on each side. There can be worsening of mood and memory. The mood tends to be mostly transient and the memory is mostly subjective and with not shown on the formal neuropsych testing, but those are potential issues with them. Then there's a variety of other ones that are not approved yet, but being studied, so focused ultrasound, transcranial magnetic stimulation, the vagus nerve stimulator, just through the skin, and a subscalp stimulation as well. This is a trigeminal nerve stimulation. So we published one study looking at resection based on long-term RNS system recordings. So this was basically looking at everybody who got resection after RNS recordings. So there were 157 patients who had bilateral depth electrode recordings with the responsive neurostimulator system. And 16% of those, so it's not a small number, went on to have mesial temporal lobe resection. All but one of them continued to be treated with the stimulator after resection, mostly on the other side. And then we had long-term follow-up in them. So 9 of these patients turned out to be purely unilateral with their long-term recordings, meaning they had a year or more of purely unilateral seizures. All 9 of those became seizure-free after they had resection. Then there were 21 patients who had bilateral seizures with at least half or more than half from one side, and 15 of those patients actually became clinically seizure-free after their resection. Some of them still had electrographic seizures captured with the device, but clinically they were seizure-free. And every single patient was considered a responder, meaning at least 50% improvement. The other thing we learned from this was that the short-term intracranial EEG monitoring is often misleading. So in 7 out of 12 cases, it was misleading here. Either it said it was bilateral when it wasn't really, or it said the wrong side was the predominant one. So you really can't rely on a random 1 or 2 week recording session. We know it takes much longer than that. The median is about 2 weeks before you'll see the first seizure from the second side. And it's not rare to take more than a month to see the first seizure from the second side. And people sometimes cluster at one side at one point, and then weeks later will cluster from the other side. So for anybody with evidence of bitemporal, we tend to implant a responsive neurostimulator that gives you a chance to treat it, but also if that's not adequate, you have years of recording on full meds in their usual daily life that help guide future resections. So what about head-to-head comparison of these devices? So there are several reviews that have tried to do this. This one was using 3 years of follow-up and looking at the seizure reduction. So you see a large overlap with maybe the VNS a little below the others. This was one looking specifically at seizure freedom from an International League Against Epilepsy Commission. You see the RNS seizure freedom numbers are a little higher. This is the same scale than the DBS numbers, with just over 20% in 9-year follow-up and closer to, I think, was about 11 or 12% with DBS. And VNS was about 3%, according to this review. So for seizure freedom, RNS is a little better. So just some summaries on the devices. The vagus nerve stimulator, these are some of the pros. It's the least invasive. It does seem to help depression as well. Cons are the efficacy may be a little less than the others, the voice change and the effect on sleep apnea. The responsive neurostimulator, the data you get is one of the big pros, and the efficacy, including some cases of seizure freedom, is pretty good as well. And then there's no adverse cognitive or mood effects. In fact, the cognition seems to improve. But you do need to be able to localize with this, and you can only treat 1 or 2 foci, or you can treat the thalamus. The deep brain stimulator is easier to use. You don't need to localize. Efficacy is better than the vagus nerve stimulator. You can give extra stimulation when you need it on demand, but it doesn't give you the same kind of recordings. They're just starting to get some kind of recordings from this, but not that useful yet. And you do have to worry a bit about worsening depression or disrupting sleep. So there's lots of interest in the thalamus recently. I'm going to be running out of time, so I'll just quickly mention some of this. I will mention we have a trial that's going on now that Hal Blumenfeld runs, where you're stimulating the central lateral nucleus, and this is to keep people awake if you can't stop their seizure. So they have a focal aware seizure instead of a focal impaired aware one. It's a fascinating study. I think all the patients are actually implanted already. And I'll just mention this one trial from Australia that did deep brain stimulation of the centromedian nucleus for Lennox-Gastaut. Basically, the bottom line was for the diary recorded seizures, there was an improvement, but it didn't quite reach significance. It was 50% responder rate versus 22% in the people who were randomized to having their stimulation off. But for electrographic seizures, it did reach significance. So it was a 59% were responder on EEG as the very objective method versus none of the placebo cases. So that's a pretty prominent benefit. And 95% of the families reported improved alertness. But this was in young adults, not kids. And this just graphs of showing the electrographic seizures were markedly decreased. So I can't talk about advances without mentioning artificial intelligence. So here's a couple studies showing about computers reading the EEG. So in the epilepsy monitoring unit, this one detection algorithm was shown to be non-inferior to human experts. Not perfect, but neither are humans. Another one looking at scalp EEGs could identify epileptiform findings better than the experts. This one not only says whether there are spikes or not in an EEG, but also says whether the whole EEG is normal or abnormal, whether it's focal or generalized. And it was about 90% accurate and was equal to the experts. So yeah, the computers can read the EEGs. There are studies suggesting machine learning can also tell somebody with epilepsy from somebody without, and even when they don't have spikes. And there's a really fascinating animal study using just video, so no EEG. It could tell just observing the natural movements of the rodents that which ones had epilepsy, which ones were on meds or not, which med they were on, and whether it was low or high dose is pretty remarkable. That's published in Neuron. Take a look at that. I think this is my last slide on the near future. So we'll have transcranial focused ultrasound, especially low intensity focused ultrasound is very interesting in that it can modulate electrical activity without causing permanent or any histologic injury. Other transcranial ways of stimulating the brain, whether it's magnetic or direct current, studies going on in all of those. We're going to learn a lot more about where to do neuromodulation. Many more nodes have been suggested, and we'll get better and better identifying people's epileptic networks and knowing where and how to stimulate them. Seizure forecasting and prevention, I mentioned some of those. Hopefully we'll have more anti-epileptogenic agents. Stem cell transplants, that is actually now in clinical trials in people with medial temporal lobe epilepsy. These are GABAergic interneurons being implanted. So it's actually started now. We'll get results soon. And you'll hear a lot more about artificial intelligence in almost every aspect: diagnosis, EEG reading, MRI interpretation, etc. So yeah, AI is here to stay. So stay tuned, there will be a lot more advances. All right, our parting Paul, this is for you to answer. All right, so these are your options. So you are most excited about the following advance. You'll notice you're not allowed to say none of the above. So new medications, new devices for recording. So these are the diagnostic devices, seizure forecasting, stem cell transplants, or neuromodulation.
It looks like 51% of our audience is most excited about new devices for recording EEG and identifying seizures at home. Then it was 35% for seizure forecasting, and then in the 20% was all the other choices. So
okay, well, I'm glad I added the diagnostic device section. All right, well, on that note, I will thank everyone for their attention, and I'm happy to take some questions.
let's see. I think we have time for a couple of questions here. This colleague writes, "What is habitual seizures?"
That means the typical ones that they have spontaneously at home. So the same symptoms, semiology, and the same EEG pattern, assuming you've captured some spontaneous seizures as well.
Okay. This question this pertains to an 8-year-old. If seizure has not occurred in the last 2 years and scalp EEGs show interictal discharges, can we stop ASM?
Probably not.
Probably not.
If you still have epileptiform discharges, the risk of recurrence is pretty high.
Okay.
I guess it depends if they were focal seizures that never generalized and the person's not driving and all that, you could still try, but the odds are not too good.
Even following epilepsy surgery in pediatrics, many of them still recur, meaning seizures, or
right. Yeah, well, that's where we have all the devices that you can use. Even in all of the studies of devices, a lot of patients had prior epilepsy surgery, and they still do well. And I didn't talk about it, but you can combine devices. There are people who have 2 or 3 stimulators, and you can combine surgery and devices. Sometimes we even do that in the same procedure. If we can't resect the full focus, or we can only resect one of 2 foci, we'll often put a stimulator on the second one or over the eloquent cortex. So you can combine all these things now. So just a lot more options than we used to have.
Well, I think you started sort of kindling here about AI. Do you think AI will replace remote monitoring technologists?
I think they're going to help, but as you can see, the EEG world and diagnostics are expanding pretty rapidly, and we're going to have more and more of these ultra long-term recordings. So the computers are going to help, and they're going to help minimize all that, but there's still going to have to be technologists and physicians, both to help develop these things and to help supervise them. I think we're still fairly far away from computers completely replacing us. So far, they're just a helpful adjunct to save time and to help you focus your attention.
Okay, I think we have time for one last one here. With RNS versus DBS, would there be a selection bias with those patients where DBS patients would be more severe cases that would lead to less seizure reduction?
Yeah, that could be. If you think you can localize, they may be shunted more towards the responsive neurostimulator, and the harder ones or more multifocal might get DBS. But the response rate in some of those severe syndromes are actually pretty good with the DBS. So I'm not sure that would bias the response rate, but yes, it could be a more severe population. Yeah, as far as overall efficacy between DBS and RNS, they're in the same ballpark, and until you have a randomized trial, it's going to be very hard to know. I think it's more the expertise at your center, whether you're localized or not, and whether the data you get from the RNS system is useful to you.
So on behalf of Natus and our Neurotraining Academy, it's been a pleasure having you join us. And again, I would like to thank our speaker, Dr. Lawrence Hirsch, and this will conclude our presentation. So thanks everyone for your participation. Enjoy the rest of your day or evening, and we will certainly look forward to seeing you next time.